Thank you, my teacher, Professor Afifi, for the kind introduction. Can you hear me? Dr. Hara, Dr. Haba, can you hear me?
Yes.
Okay.
Yes, okay. Good.
So now, today my topic is the management of paragastric fluid collection, recent advances and tips and tricks. I mean by paragastric fluid collection, not only pancreatic pseudocyst. Of course, pancreatic pseudocyst is the common, but I mean other paragastric infected fluid collection like biloma and abscess. They all have the same line of management. Pancreatic fluid collection is a frequent complication of acute pancreatitis. The incidence of pancreatic fluid collection is, in some reports, might reach 42%. The incidence of pseudocyst might reach 6.3%. To understand the difference between pseudocyst and one necrotic world of necrotic tissue collection, we must refer to pathophysiology. Acute pancreatitis might be acute interstitial pancreatitis or necrotizing pancreatitis. Acute interstitial pancreatitis might lead to acute pancreatic fluid collection. If this collection persists for more than 4 weeks, it will be pancreatic pseudocyst. And acute necrotizing pancreatitis might complicate by acute necrotic tissue collection. If this collection persists for more than 4 weeks, it will be walled off necrotic tissue collection. We have to differentiate both entities. Today's lecture is just about the tips and the tricks. So, in managing the pancreatic fluid collection, you must keep in mind patient complaint, cyst maturation, cyst diameter, how to choose stent, site of puncture. First, patient complaint. Please don't attack asymptomatic cyst because 70% of pancreatic fluid collection might resolve spontaneously. Take care about the maturation of the cyst. This cyst is mature. It already has 4 weeks from the collection, and this cyst is not mature, so you shouldn't attack this cyst. Cyst diameter, please remember 6 centimeter, because if you are able to use hot aqueous stent, the cyst must be more than 6 centimeter, because the delivery system of the stent need the 6 centimeter to can deploy the stent. Very important. Types of the stent. There are many types of the stent you can use. The hot aqueous stent, biphalangid dumbbell stent, tubular stent, and double pigtail stent. And you can choose the suitable stent for each patient. For example, this biphalangid stent or lumen opposing stent for the cysts that have many necrotic tissue, we already performed in our unit. And this cyst is clear cyst, so we already performed the cystgastrostomy using just double pigtail stent was enough to treat this patient. Number 3, this cyst has minimal necrotic fluid collection, so just biliary stent was enough to treat this patient. Site of puncture, if the cyst diameter is, if it has high diameter, you should select the distal point to puncture, because if you need further endoscopic necrosectomy, you can access easily. If you puncture near the antral site, compared to puncture near the fundus of the stomach. Finally, I will present this case we already published during my stay at Aichi Cancer Center. It was a female patient, 57 years old, history of pancreatitis. He presented by fever and abdominal pain. CT showed perisplenic fluid collection of 4.3 centimeter and diagnosed as post-pancreatitis splenic abscess. Let's check the video. At first, we make endoclip at the cardia to avoid transesophageal puncture. We visualize the abscess. Of course, first we use linear echo endoscope, and finally for intervention we use the forward view echo endoscope. Puncture of the abscess by 19 gauge needle loaded by 25 guide wire and the coiling wire inside the abscess. After that, we dilate the tract using coaxial dilator, electrocautery dilator. And finally, we deploy 8 millimeter, 8 centimeter, fully covered, self-expandable metallic stent. Please notice this point because it's very important. We deploy the stent completely. So now the stent is open inside the abscess and inside the scope channel. Now the delivery system is out here. After that, we insert 7 French 10 centimeter double bed stent within the fully covered stent over the same guide wire. And finally, we down angulate the echo endoscope, directing both stents to open in the stomach. So what we called stent in stent in managing one of the paragastric fluid collection, in this case was the splenic abscess, post-pancreatitis splenic abscess. This is the metallic stent and inside the double bed stent. This is the schema of the procedure. This is a splenic abscess. This is the metallic stent and inside the double bed stent. Please remember, it is double bed stent, not double pigtail stent. The use of the forward view echo endoscope is easy for such intervention because the scope has front view orientation, making puncture and the device and the stent deployment easier than with linear echo endoscope, because the forward view echo endoscope has direct and the front orientation to the cyst or the lesion. There is no lever, no need for this angle. But as I said, you must examine the cyst clearly first by linear echo endoscope, because it is standard echo endoscope. Why stent in stent? To prevent kinking and the early stent dysfunction. Also, collapse of the abscess or cyst might lead to some bleeding. Stent in stent prevent bleeding after collapse of the cyst or abscess. over the edge of the metallic stent. Why double bit stent, not big tail stent? Because sometimes we need to keep the plastic stent in the abscess or in the cyst after removal or extraction of the metallic stent. So when we extract the stent, double bit stent keep in the cyst. If we use the double big tail stent, it's come out with the metallic stent. We already published this technique in Journal of Hepatobiliary Pancreatic Science. This is my picture in Aichi Cancer Center during my training, EUS-FNA with Dr. Okuno. This is our mentor, Dr. Hara, teaching us EUS-HGS at ACC. This is Dr. Muhammad and Dr. Ahmed, who start EUS era with me in our unit. This is our team in Al-Azhar University Hospital. We have already many doctors from Egypt and from nearby countries came to our unit to learn EUS intervention. This is our team. This is our second generation, Dr. Mahmoud. Now he already can perform screening and EUS-FNA perfectly. Also Dr. Ali Ibrahim and Dr. Yasser. Dr. Ahmed Shaqir also can perform. And this is the picture at ACC. Thank you very much.